Alright guys, getting right into EKG basics. Alright, the starting point of what we need to do in order to start recognizing our EKGs. So we have to start understanding some concepts of EKGs. Alright, so we're going to start with the all important Einthoven's triangle, which is what this triangle represents. And it's an important concept to get down when you're talking about polarity and actually how the EKG is going to read and interpret our EKG. So Einthoven triangle. So we got a little triangle here. We're going to draw it. And this is a little doodle to kind of make let you guys understand. When we put our stickers on our patient, we have, white right, smoke over fire, and we have our green lead. Together that makes our 4 lead. But we don't need this green lead here to make our basic 3 lead, which is what this diagram is showing. This 4th lead is going to give us 3 more leads that we're going to talk about later. All right, so we got our white lead. All right, that's a W to the right, and we have our black lead on my left arm, and smoke over fire. So I have my red lead. All right, so that Einthoven's triangle is going to make our bipolar leads. And we're going to go over them each one because as paramedic students we have to memorize each one. So if you look at this diagram here, you're going to have a lead 1 direction. Lead 1 always goes from right arm to left arm. That's your lead 1. Okay? One concept to keep in mind when reading EKGs is knowing that electricity is always going to flow from negative to positive. That's how the EKG is going to read it. All right. So when you're looking at lead 1 and you have a test question that says, where's the negative electrode in lead 1, your answer should always be right arm. All right. So lead 1 is going to go negative to positive from right arm to left arm. Now we have lead 2. All right. Lead 2. Lead 2 is going to go from right arm to left leg in a downward angle this way. That makes our lead 2. So the monitor is going to read lead 2 from looking at right arm to left leg. Then we have lead 3 on this side. Okay? And when the monitor looks at lead 3, it's going to turn this lead here, this electrode, to my negative lead, and this electrode to my positive lead. So yeah, I got cat's eyes. Cat's eyes down here. All right? It's always going to be positive. And a little cat meow. It's always going to be positive at the foot, and that is my lead 3. Together those 3 leads make my Einthoven's triangle. So the monitor does this all at once. All right, it's going to create my lead 1 from right arm to left arm. It's going to create my lead 2 from right arm to left leg, and it's going to create my lead 3 from left arm to left leg straight down. And I got 3 views. These 3 leads are called my bipolar leads. Okay, they are bipolar leads because each view has a negative and a positive electrode. All right, we need that. We need these 3 in order to diagnose what the actual rhythm is. When we're diagnosing rhythms, we're always looking at lead 2. And that's what we're going to be going over is our lead 2 recognition. Because once we get lead 2 down, then we can start looking at the other leads in order to tell us what else is going on. All right. So going over our PowerPoints here, have gel-centered diaphoretic electrode. Our patients might be diaphoretic, in which they won't stick. And we have things on the truck like benzoin and stuff like that that'll help us stick the electrode to the patient. So we get a nice clear view of the patient's electrical activity. All right, you may need to shave their body hair. You may need to tell the patient to stop taking such deep breaths or not move, or maybe even park the truck because of that whole 60 cycle interference. That might prevent us from getting an accurate EKG, all right? If something is disconnected or the truck is shaking or a patient's hairy or they're sweating, it might represent an artifact on our EKG. Wavy baseline might be due to the patient moving. That is a classic test question right there. I'm going to circle it. Questions like, you have a wavy baseline. What is the most common cause? And your answer would always be patient movement or muscle tremor. Okay, that's an important question there. that you might see again on an exam. All right. So we already went over the bipolar leads. We have lead 1, lead 2, and lead 3. Both have a negative. Both have a positive electrode that give us that bipolar lead. We will use lead 2 as our diagnosing view. Why, do you ask? Well, let's draw Einthoven's triangle again. All right. And if you remember, if you listen to the first one or watch the first one, you can imagine our heart here in the center. Lead 2 follows the electrical conduction pathway perfectly, down and to the left. That's the perfect view for my electrical conduction system, our heart traveling down like that. So that'll give us a nice upright representation of what electrically is going on in the heart. So we tend to always look at lead 2 to diagnose our rhythms because it follows the electrical conduction pathway perfectly. All right? So lead 2 is our monitoring view. Those are our bipolar leads. We already talked about that. Another key concept to keep in mind that, again, drawing Einthoven's triangle, we have to get used to that Einthoven's triangle. Hang on. Got the swirly beach ball going on here. But anytime you see a positive upright deflection on an EKG, it means that electricity is flowing towards the positive electrode. Now I'm going to go, okay, that quit on me. So I'm going to go get my screen marker again. Start that up. All right, back to drawing Einthoven's triangle. Draw it thicker here. All right, Einthoven's triangle. Whenever I have electricity flowing towards a positive electrode, it's going to represent positive on the EKG. So we already said my negative lead in lead 2 is my right arm, and my positive lead in lead 2 is at my left leg. It's where the electrical conduction of the heart is actually flowing towards this positive lead. And because electricity is flowing towards this positive lead, it's going to represent mostly upright on an EKG. And when I say upright on an EKG, I'm meaning that the majority of the EKG is above the baseline. All right? It's above the baseline. And that's an important, really important concept to understand, especially when we start talking about our rhythms of the junction. And just quite the opposite, any electricity that's flowing away from the positive electrode will represent negative on the EKG. All right? Biphasic waveforms just meaning that the electrical axis is going in the positive and negative direction. And this is the term that I've been going over. And it's right here. Einthoven triangle. That's what we've been drawing this whole time. All right? So moving on. Whenever you start learning how to read EKGs, or even when you become good at it, always use a systematic approach. Even seasoned paramedics get this lackadaisical attitude when they look at an EKG because they get good at them. And they read them, and they just kind of glance at it, and they come up with this working diagnosis just based on their first glance. That's not really good paramedic practice because there are many instances where you can just glance at an EKG and you think you know what you're looking at, but on further review of it, you're missing a PAC, or you're missing that the patient is actually in an AFib, or you're missing the fact that they are in a junction, or you miss a first-degree heart block. You have to take your time and read EKGs, examine them in a systematic way. That is very important. Don't get lackadaisical, especially when you're first starting out reading these EKGs, all right? Now, our last conversation, we talked about the Pwave, all right? Our Pwave, by definition, we'll draw it right here, is our first upright deflection on the EKG. Normally small, upright. That is key, all right? You want it to be rounded. Lasts usually 0.06 to 0.11 seconds, and we're going to go over that on the EKG paper here in a second. All right? But the the Pwave, right here, represents that the atrium are contracting.
Rest.
Sorry, guys, I had to pause that. I had a call. Anyway, we're looking at the P waves again. So normal P wave would be upright and rounded, all right? But when I see a P wave, all I'm thinking is that it is an atrial P wave. I don't know if it's from the SA node. I know it's from the SA node because it's rounded. That's what I'm looking for. Okay, so Pwave equals atrial depolarization. All right. P-waves are really important because they give you clues to where the pacemaker site's actually coming from. All right, so we're looking at P-waves. When we're looking at P-waves in the rhythm, we want to see that there's P-waves and that every QRS complex is preceded by a P-wave. All right, so there's a P-wave for every QRS complex. All right, moving on. We have our PRI. All right, our PRI represents full atrial depolarization, okay, from the P wave, from the SA node all the way down to the AV junction. That's what that PRI is. All right, the PRI is important because we use that to diagnose many other rhythms. Here's our paper. We want to make sure that our PRI is between 0.12 and 0.20 seconds, or between 3 and 5 small boxes. All right, so I'm going to pull up an image here, and we're going to look at that for a second. Here is some EKG paper. Now, the EKG paper has little boxes here, and they have small boxes. All right, so I'm going to decrease the size of my pen here so we can all see. All right. So we have big boxes, and we have little boxes. All right. Right there, that's a big box. I'll change the color there so we can get a little difference there. This big box equals 0.20 seconds. Why? Because each one of these little tiny boxes, 1 square millimeter, equals 0.04 seconds in time. One of those little boxes there. So 5 of those boxes would be 0.20. Right? Left and right on EKG represents time. Right, as represented here. So 1 little box, we got 0.04 seconds. 2, we have 0.08. 3, we have 0.12, and on up. All right, so that's our EKG paper with the little boxes and the small boxes. So we want to make sure that when we measure our PRI, it's between 0.20 and 0.12, right? Conditions like Wolff-Parkinson's White and LGL or conduction defects, or we're going to go over in another at another time. Then we're looking at our QRS complex. Our QRS complex has, like it says, 3 different waveforms. We have a Q, an R, and an S. All right. So we have our P isoelectric line. The first downward deflection after the P wave would be our Q. Then we have our R, which represents ventricular depolarization. We have the S wave, which represents ventricular repolarization. Right here, this is our QRS complex. Together, it is a QRS complex. Again, it should be followed by a P wave. We have P, QRS, T, P, QRS, T, and on and on. Right? So that would be our QRS complex. Our QRS complex also has a measurement that it should be less than, and that's the 0.12. Now, some books might say 0.08, but for all intents and purposes, we are talking about 0.12. All right. Q waves, you might see a Q wave, you might not. That doesn't change the diagnosis of your rhythm. You have to have your R wave, and you might have an S wave. All right. The R prime wave here looks something like this. All right. That's classically what we see in a bundle branch block. So we have an R wave as the first upright deflection, and then we have our S wave here, but then we also have a second R wave. That second R wave is called your R prime. All right. So that might be your RSR prime wave, or your R prime wave as it says in this slide here. All right. Talking about the J point, when we're moving on past the EKG, we got our P, we have our Q, we have our R, we have our S here. Now the J point is the portion of where your S wave comes up and meets your isoelectric line. All right. Your J point should always be isoelectric, meaning that the J point sits on this isoelectric line. So when we're looking at the junction of my S wave to my isoelectric line, I got to make sure that it is not above baseline and not below baseline. That's what we use to diagnose heart attacks. It could mean a whole bunch of different things, and we'll get into that when we start talking about heart attacks and MIs. But that is what your J point is. Your ST segment is the straw EKG here again. Right? We have our P, Q, we have an R wave here, we have an S. Our ST segment would be, let's draw it elevated, would be the point where my J point is started and where my T wave would start. That area is called my ST segment. All right? Your ST segment should also be isoelectric. We use that to diagnose heart attacks as well. So when we're talking slightly above or isoelectric or slightly below, that might be normal. But when we start talking about MIs and heart attacks, we'll get further into our ST segments. Going on to the last component of the EKG would be our T wave. Now, the T wave is sort of the stepchild of all the waves because it is the one wave you don't need to. All right, guys. Sorry, continuing. Going on to our T wave. Like I said earlier, your T wave is kind of like the stepchild of all the waves because we don't technically use the T wave to diagnose what the rhythm actually is. But we can utilize the T wave in order to kind of tell other things that's going on. You'll see a nice peaked T wave like that where it kind of looks like it hurts to sit on. Ow. If your patient is, say, hyperkalemic. All right. Or you might see a nice big, broad, tall T wave when you're looking at early repolarization. And we're going to get into all that sort of thing in a different episode. All right, so moving on. Our QT interval, this is a number that you guys should remember, 0.36 to 0.44 seconds. That tends to come up on tests a lot. So if you have a question asking you what a normal QT interval is 0.36 to 0.44. Another classic question according to with the QT interval would be, what does the QT represent? And you are looking for the answer that says all activities during QRS complex and T wave, which means complete ventricular depolarization and repolarization. So that's the answer that you're looking for with that. And that's just the start of your Q wave to the end of your T wave, and that's what your QT interval is. So here's a basic strip here. When we're looking at the strip, one of your first questions should be, is my rhythm regular or irregular? And we determine regularity in our EKG by looking at our R to R intervals. Our R to R intervals should be able to walk out, meaning that the distance from this one to this one to that one to that one are all the same. All right. If they don't walk out and they're not all the same, it is not normal. It is an irregular rhythm. So that's one of the first things you should ask yourself. First, is my rhythm too fast or too slow? Now I'm looking at my R to R intervals. All right. Are they all the same? There's a couple ways to actually determine the rate of your EKG. A quick way to do it is to get your 6-second strip. And your 6-second strip would be, you need 3 of those little hashes that are on the top of your paper. Between 2 of those hashes are 3 seconds, so we need 3 of those. That would be your 6-second strip. We're looking at the amount of R waves and the amount of QRS complexes that are within those 6 seconds. You times that number by 10, boom, you got your heart rate. All right, so that's a quick method to do it. That's your 6-second method to calculate your heart rate. Another method to do is the sequence method, which is a little bit, takes a little bit longer to do, but it's a little bit more accurate. And I'm going to pull this picture up here. And what you're doing is you're looking for an R wave that sits on one of these thick lines. All right, so you're looking at your EKG. Once you find the R wave that sits on a thick line, now you're counting the thick lines over. So this, say that your R wave on this EKG, I'll draw it out here. There we go. There's an R wave that sits on that fat line there. So this line here, if the next R wave were to sit right there, you could say that your rate is about 300, which is extremely fast. All right. So, and then we count our thick lines over. So this first one would be 300. This one would be 150. That one would be 100. That one would be 75. Your next one over would be 60, and so on. And you look at where your next R wave sits, and that would be your sequence method. All right. So I'll decrease that picture here. So there's 2 ways. Mainly, you got your 6 seconds and you got your sequence method. So know those for your exam. All right. Moving on. So the last part of this is just kind of a review of what we went over. You want to make sure that all of your EKGs, one, have an upright and rounded P wave, meaning that you have a sinoatrial P wave. Remember, P wave means atrium. Rounded upright P wave means SA node. PRI, Q wave, R wave, S wave, T wave. All right. We want to make sure that our PRI is between what? 0.12 and 0.20 seconds, or 3 to 5 small boxes. We want to make sure that our QRS complex is between what? 0.12 seconds, less than 0.12. Right? We don't want it too narrow. We want it between 0.04 and 0.12. We want to make sure that our QT interval, all right, is between 0.33 and 0.46 seconds. We want to make sure that there's a P wave before every R wave. We want to make sure that our R to R intervals walk out. It's all normal. All right. Is the rhythm regular? What is the rate? Is it too fast or is it too slow? Those are the basic components of the EKG. Until next time.